TopMedTalk.
Nick Margerrison here, welcome to TopMedTalk. This programme, COVID-19 A Case Study, Professor Monty Mythen, is an attempt to put together a programme that reflects the story that we've heard regarding Professor Monty Mythen and his diagnosis of COVID-19. Here at TopMedTalk, we were clear that this story was huge. We appreciate the potential seriousness of this virus, and particularly healthcare workers in our team have had direct experience of it. March the 16th.
TopMedTalk.
Hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk. We're interrupting normal services in response to COVID-19, that's the coronavirus 19 global pandemic, to introduce a new series. So I apologise to people who are expecting our regular podcast, but we think it's important that we have a slight change of tack. I'm joined here by Desiree Chappell, our managing editor and anchor in the USA. So when I say joined here, I'm in my house in London, in England, and Desiree, you're at home in Louisville, Kentucky.
Yep.
And we have made a decision, should I say, in response to numerous requests to switch gears from our regular recorded podcast series to deal predominantly with COVID-19.
Our immediate response was to aim to reduce contact between ourselves and colleagues down to zero if possible. Here's Monty Mythen speaking with Hugh Montgomery on the same day, March the 16th.
Now, Hugh, I'm longer in the tooth than you by just a whisker. I can already feel people saying, well, look, you two old men are sitting at home chatting to each other, being self-congratulatory over Skype or whatever technology is being used. But it strikes me the crazy thing to do is to all gather in the hospital to discuss what might happen, because the opportunities for transfecting and taking a whole load of us out by doing that when we could all be on the phone instead.
In a sense, you could say we were early adopters of the lockdown policy. Adapting to these changes as they were adopted around the world was an interesting process. March the 19th now.
Can I just run down the checklist of the things we're getting used to and see where you are on the spectrum locally now? Kids at school, not at school?
Kids are out of school.
Okay, challenging, I'm guessing.
Absolutely, yeah. A lot of homeschooling's going on.
Sort of closed our schools here. They're closing them tomorrow, but they've taken this interesting approach, which we're not quite sure how it's going to play out yet, where they're keeping the schools open for what they've deemed to be the list of essential workers. Now, because otherwise they're going to restrict the availability of the workforce, and the alternative is to ask mama and papa to look after them, which is not a great strategy.
No.
And we're not quite sure how that's going to shake down. It is eerily quiet here. Now, you often joke about the fact that any journey in London in a motor vehicle takes 1 hour.
It's my rule.
It don't at the moment.
Yeah.
Almost everything is shut down. We've got this weird rule whereby we strongly encourage the pubs and the restaurants to close and people not to go to them, which is a bit of a fudge, because if you're running one of those things, that impacts your insurance, et cetera, et cetera. Yeah. But that will all sort itself out. What we're trying to do here is not overwhelm the health system. It's not about the possibly inevitable transmission between each other. It's the when you get it is the component of it. So the mindset is all about, what can I do not to give it to somebody, not what can I do not to get it. Initially, we are going to treat everybody as though they've got COVID-19.
You have to.
Because if you look at the learning from the rest of the world, you've got no other way of telling it until you've got the testing fully embedded and fast. So you have to assume either they've got it or you've got it, or the people around you have got it. There's no other way of doing it. Many people are asymptomatic. That's pretty clear.
That's true.
We are all in this together. Chilling thing is, if we are sloppy about this, we as healthcare providers are in no way, shape or form protected from getting COVID-19. Actually, we get it more often. So the sloppier and the more pig-headed our colleagues are, the more of us and or themselves they will take down. So we need to get our donning and doffing kits. We're obviously not going to use equipment that works, if you see what I mean, but you can make up your own kit at home.
Yeah.
Of various different things, for things you can buy in the DIY store. And practice our routines.
That's right.
So providing we stay well and our energy levels are up, TopMedTalk, we're all over it.
Absolutely.
Thank you to our very generous sponsors, in particular Edwards Life Sciences. Thank you to our employers who have worked out wonderful rotas that mean we're going to be very, very busy, but in between those very, very busy days when we're not cross-covering, we can do a bit of this.
Yeah.
Throughout this crisis, the threat to healthcare workers has been clear. Here's Monty Mythen speaking with his friend and colleague Mike Grocott, Sunday, March the 22nd now. It's possible that Monty unknowingly has contracted coronavirus by this point.
So I'm at my house in London, in England, doing a bit of distancing. Going to go into the hospital tomorrow, see how things are going on. I've just caught up with Professor Mike Grocott from Southampton, who's a regular on TopMedTalk, who's just come off a major shift in Southampton at the hospital there. Mike, how's it been?
We're good. We're a little bit behind London from what I can gauge. But I think in terms of the breaking wave of COVID, the uptick on that epidemiological curve that we keep seeing, I think we are probably a few days, maybe a week if we're lucky, behind what I can see happening in London and what we've seen happening in other countries, Italy in particular.
Yeah, very, very important stuff. Now, what have you done about the recently retired, Mike, or people who've been deployed in other spaces? Because, as you know, we celebrated what I thought was my last day on call on intensive care after 35 years or whatever it is. But I'm back on the roster and I'll be back in again soon, which, you know, very important that we all do our bit.
So we, in common with some other places, we've actually had a couple of our doctors step off the rota because we're concerned about the clinical risk, for reasons I won't go into the detail of. And I know that other centres have looked at putting an age bar around 55, maybe a little bit older, saying actually the risk to the individual practitioner is too high and they should be deployed on non-frontline activities. We've tried to release those that might be at risk from clinical duties, certainly on the intensive care.
Over 55, wow. I mean, that for our intensive care unit, you know, my colleagues.
I do.
It's going to leave a lot of rota gaps. I think this is going to go out on the podcast. A lot of people are going to hear that. But
we didn't do the age thing in Southampton, but we have certainly released one colleague.
It depends on what you call the front line as well, because I mean, from the point of view of doing ward rounds once everything is under control in full PPE, I don't see any major risks in that compared to a regular day at the office. This may sound for those people listening who don't do intensive care, this may sound as though I'm not taking this seriously, but we're very commonly and regularly exposed to very serious risks. So protecting ourselves and protecting our patients is every day at the office. From the point of view of the front line being evaluation of yet determined whether they do or don't have, and airway management in the frenzy and intubation, etc., that sounds absolutely sensible to me, because there are plenty of strong young people who can offer to do that.
Yeah, and I mean, I think if you take the PPE seriously and the donning and doffing, it should be very safe. But we do have to be really, really methodical about doing that, I think.
Now, I'm going to come back to the donning and doffing in a moment. Now, we've all, I'd say, thankfully, been grounded, which is, again, it's really rather pleasant for those of us to do a little bit more travelling, allegedly in the name of spreading the academic mission.
By March the 25th, we directly addressed the possibility that one of our team could have COVID-19. Have a listen.
TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree Chappell, your host, and we are coming to you with coverage of the COVID-19 crisis. I'm in Louisville, Kentucky, but I'm joined by our editor-in-chief in London, Monty Mythen. Hi, Monty.
Hi, good afternoon, Desiree. Good morning for you.
That's right. We are dealing with the time differences for sure. Monty, how are you feeling? I know that you have been a little bit under the weather.
Yeah, I've definitely had the lurgy. So we will find out.
Can you translate the lurgy for?
I have had what you might traditionally regard as a nasty little cold or a not too bad flu. So I've had some sort of symptoms that might be consistent with COVID-19, some intermittent elevated temperature, some muscle aches, some cold shakes at night. Now got a little bit of a cough that's not too irritating, but it's definitely there. But good news, because I'm hoping to go back into work as soon as possible. Our rapid tests are coming online. So I hope within the next 24 hours, I can be tested for COVID-19. And if I feel better and I'm COVID-19 negative, I won't have to self-isolate unnecessarily, because we're going to have no one to go to work if this carries on this way.
You haven't even been into work
I have
so
not.
far, so this would be a community acquired.
We've been fully self-isolating, and actually we've been through the lockdown period now. But I work in a household where my wife was working at a school and my student children have come home. So It's highly likely that I would get COVID-19 because, as we now know, many people are asymptomatic COVID-19 carriers, and that's much more common in children and younger people. And therefore, you just have to assume once you get people into their own home, which is the sort of whole idea, you work out who gets it, doesn't get it, how bad it is, how bad it isn't. For us as healthcare workers, what we need to do is filter out the true head colds from the COVID-19s.
So tell us about what's happening there in the UK as far as the lockdown situation is.
Well, a full lockdown was announced by our Prime Minister. What one might traditionally regard as quite draconian measures. In other words, you have to stay at home. There are rules wrapped around that with regards to who can go where and for how long. I think because it was a staged introduction to get to that point, and now people can see for themselves how serious this is. I mean, COVID-19 has touched everyone and every family in some way. It's going pretty remarkably well. People are being quite sensible about it now. Can we listen to our Prime Minister?
The time has now come for us all to do more. From this evening, I must give the British people a very simple instruction. You must stay at home. Because the critical thing we must do to stop the disease spreading between households. That is why people will only be allowed to leave their home for the following very limited purposes. Shopping for basic necessities as infrequently as possible. One form of exercise a day, for example, a run, walk or cycle, alone or with members of your household. Any medical need to provide care or to help a vulnerable person. And travelling to and from work, but only where this is absolutely necessary and cannot be done from home. That's all.
And I think what we have been told about COVID-19 since the very beginning, but have been slow to listen to, is the reason it is reached epidemic or pandemic proportions is because it's novel, it's exceptionally transmissible, but not for the whole group of people who get it very lethal. Therefore, it's an ideal spreader. And from what we've seen from the data that's come through now, it seems that in children, for example, the vast majority who get it, and if you've been in a school environment, you probably have got it, are asymptomatic spreaders. So there's almost no child has been reported as becoming very unwell or seriously unwell, but a high incidence of asymptomatic spreading. Then as you go up into the slightly older people, the teenagers, the students who are going to find it harder to stay apart, they tend to get it less badly, and it tends to almost never be fatal, which is great, but that means they still have a tendency to want to find each other to have fun. So it doesn't take long. The estimates are that, if you infect somebody else and you don't get it under containment, that one contact for you rapidly becomes 50,000 cases.
Yeah, I think we can listen to Hugh Montgomery about why we're having to do this because the spread is so virulent.
Normal flu, if I get that, I'm going to infect, on average, about 1.3, 1.4 people, okay, if there was such a division.
Yeah.
And if those 1.3, 1.4 people gave it to the next lot, that's the second time it gets passed on. By the time that's happened 10 times, I've been responsible for about 14 cases of flu. This coronavirus is very, very infectious, so every person passes it to 3. Now, that doesn't sound like much of a difference, but if each of those 3 passes it to 3, and that happens at 10 layers, I have been responsible for infecting 59,000 people. Now,
I actually wasn't on top of that maths when you were doing that. Okay, that did come as a shock, yeah.
Right.
Very good point. Monty, you said that, you were talking about the children that are typically asymptomatic.
Sorry, Desiree.
You are coughing.
Sorry, ma'am. As far as we know, you cannot transmit COVID-19 down the internet.
No, so I said just cover your computer.
And I am zoned off in my own space at home, which is all wiped down and secure.
And they're bringing you food and drink.
Pizza diet. It's the only thing you can slip under the door. Boom. The old ones are the best. So that's what we heard from Hugh, is that it is that transmissible. And I think the thing that we can understand early on why people said, you've got COVID-19 probably if you've got a really bad cough and a high temperature. Well, that was just to filter out the numbers. I can understand why the people communicating said that to begin with. But for a while now, we've recognized that actually it is nobody's protected from it, and at this stage it's highly likely that all of us have got it or will have it shortly, and many of us will be asymptomatic or have mild colds. So then now at this point, and it has been that for a number of days now, we should be regarding everyone as being a risk to us and us as a risk to everybody else. You're now increasingly much more likely to get it from the person changing next to you in the changing room or the person who's checked your ID on the way into the hospital. So I've seen some significant movement in the last week in institutions in London, but I still get this slight sick feeling in the pit of my stomach every tweet I see from people arms around each other celebrating the fact they've done another great handover or have had another dance to celebrate the quality of their ability to be at work. And it's great to have fun, etc. But the distancing rules for you as a practitioner once you cross the line into the hospital are exactly the same as for when you were outside the hospital. So let's work harder on that, please. And the relevance of that, Desiree, which I think we're learning more to understand, because most of us in the wealthy worlds that we live in haven't properly dealt with epidemics before. Mm-hmm. So, I mean, people who've been in places where Ebola has broken out have got very, 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 very good at this. We're probably doing our very best now to flatten the curve from the point of view of presenting patients. Now, that is going to be correctly referred to as a tsunami of people requiring help. But it's not clear to me that we made the right moves to flatten the curve for the workers. So because the people are gathering together in hospitals still and still having their regular practices of face-to-face handovers and meetings, and as I very bluntly said last week, spraying their ideas into colleagues' coffees at meetings, you know, everyone needs to, which is happening quickly now, everyone needs to get away from that and spray your ideas onto your computer that you wipe down afterwards, or your phone, or whatever it is.
Yeah. And break rooms, we've got to get away from that.
No, get away. You'd be better off if you had an outside area, to go to your lonely old bench and take your own lunch out there and consume it and get a bit of fresh air and sunshine, if such a thing is possible. And that's a bit tough because you want the camaraderie, but you can have the camaraderie by spacing yourself out as far out in the room as possible. And or when you get home, you know, we're doing almost all virtual meetings now, and they're getting to the point they say, well, when do we have the virtual Friday evening drink together?
Yeah.
You know, and have a bit of socializing, because as you get good at this, the quality of it is excellent.
It really is.
Definitely, I'd actually say that when you've got good at it, it is superior meeting interaction than being in a meeting room.
Thanks for listening to part 1 of COVID-19, a case study, Professor Monty Mythen. This is the final clip, and this is the last part of this first part of the programme. Do make sure that you listen to part 2. It'll be appearing in the podcast feed within the next 24 hours. Unless, of course, you're listening to this programme a long time after it was released, in which case you'll find it on the website now, TopMedTalk.com. This is the final part of this programme, and part 2 will follow. Have a listen.
Top Med Talk.
Hello and welcome to Top Med Talk. I'm Desiree Chappell, host, and we are covering the COVID-19 pandemic and crisis from the front lines. Our conversations in the past week have spanned the globe, and we continue to bring the latest updates as long as we can before we're called back into action. Now, you know, I'm usually joined by our editor-in-chief, my partner in crime, my wingman. But if you've been following us on Top Med Talk, you've heard that it's entirely possible that he is ill with COVID himself. He's been febrile. He's been experiencing chills and rigor for the English speakers out there. He's doing okay, but much like what is reported, he has swings and kind of that up and down, feeling good and then not feeling so good. So we hope and pray that Monty is okay. He's actually hoping for a positive on this test so he can move on and get into the front line as soon as he can to start caring for patients there in London. So Monty, we wish you the best and hope you get well soon.
We appreciate the potential seriousness of this virus, and particularly healthcare workers in our team have had direct experience of it. We hope you're safe, and we hope you can continue to listen to Top Med Talk. Don't forget to subscribe and connect with us on social media, either Twitter, Facebook, LinkedIn, or our own YouTube channel. Also, if you'd like to feed back to us and be involved in a future program here on Top Med Talk, email contact@topmedtalk.com. Or if you want to email me personally, I'm the producer of the show, nick@topmedtalk.com. Hope to speak to you soon. Thank you for your emails from everyone who's already emailed us. we couldn't do the show without you. Also, speaking of which, thank you to our sponsors, most notably Edwards Life Sciences. We literally could not have done this without your support, and we're very proud to thank you here on TopMedTalk.
TopMedTalk.